Chain Drug Review, and Mass Market Retailers Video Forum. Brought to you by the Emerson Group.
Hello, everyone. I'm Jeffrey Wolt, Editor-in-Chief of Retail Media IQ. Welcome to our video forum. Today, we're thrilled to have as our guest Ellen Kelsay, President and CEO of the Business Group on Health. Ellen, great to have you with us. Perhaps you could begin by telling us a little bit more about what the Business Group on Health does and what its mission is.
Yes, Business Group on Health was founded over 50 years ago in 1974. So we are the longest standing and the largest nonprofit association representing employers who are the largest healthcare purchasers and payers, of course, here in the U.S., although our members are also multinational employers, and they are providing healthcare and well-being services to their workforce in the U.S. as well as in many other countries around the world. And in addition to those employers, we also have what we call industry partners. It is anybody else that's providing products or services to employers on behalf of workforce health and well-being. So when you think about industry partners, that is any entity ranging from health plans, PBMs, pharma companies, to health tech, consultancies, data warehouses, you name it. And we're bringing these different stakeholders together all the time, in person and virtually, to talk about some of the more challenging health and well-being issues confronting their workforce today. So we convene on topics such as drug pricing, healthcare quality, delivery system transformation, mental behavioral health, global healthcare issues, broader well-being issues, innovation, and we create, based on those forums, a lot of resources that we then share back out with our membership community. And we take all those insights and we represent employers' interests to the market, as well as on the Hill and with the administration.
You recently published your trends to watch for 2026. Maybe you could give us a few highlights.
A number of the trends that we focused on that I'd be happy to explore more in depth with you in this conversation really start off with against the backdrop of healthcare costs in the United States. We have, all of us, been talking about healthcare costs as being a challenge in the U.S. for decades. This is not a new topic. So what's new about it this year, and why did we call it forward as a trend, is it's the highest trend that we have seen in over a decade. We are seeing 9% healthcare trend in 2026. Again, it's the highest in a decade. And when we looked back over that 10-year period, it's a 62% compounded increase over that 10-year period. So quite startling when you look at that. And within that trend, there are many drivers. And then we've got a number of conditions in the United States, as well as I said, globally, but in the U.S. here, that are driving those numbers. Certainly cancer is the top driver of healthcare costs, followed by musculoskeletal, cardiometabolic disease, and mental health conditions. Certainly could not have this conversation without also talking about the effect of GLP-1s and what that has done to healthcare costs. And that does set the backdrop for what we then dived into more deeply in the trends to watch, is some things that will precipitate against that backdrop of alternative strategies that employers will be considering, some focus on prevention.
You mentioned costs as being number one issue. How do you see the increasing cost impacting the benefits that employers offer to their workforce?
Yeah, employers are very concerned about affordability for the workforce. Certainly, their affordability as a plan sponsor is a top concern, but they also know that the workforce have, just general with the economy being the way it is, real concerns on their affordability across the board, whether it be housing or food or healthcare. When it comes to healthcare in particular, lots of concerns about employers and very little appetite for cost shifting. We don't see many employers who are looking to raise premiums or do a ton of dramatic plan design changes that would cost shift to the workforce. We may see some of that, but that will really be as a last resort. Employers are going to do more that they can to look at their healthcare partners to see, are those partners delivering the right outcomes? Are they providing high value services? And employers are going to eliminate some vendors that are not cutting it in those areas. We also see some employers who are going to be doing increased RFP activity. So they're going to be looking at alternatives, whether it be alternatives to the incumbents or looking at the incumbents to do a better job on pricing, on quality, on data and reporting, on audit rights, looking at some contractual terms. So we do see a lot of activity from employers in terms of market evaluation. When I mentioned alternatives, we also see a number of employers looking at alternative health plans, alternative PBM models, in the hopes of driving towards greater transparency, perhaps in the pharmacy space, rebate-free models, less restrictive audit rights on their plan. And then increasingly, I mentioned earlier, a focus on prevention, back to basics was one of the trends we called out. This real focus on population health and the need to get upstream to hopefully prevent chronic disease or more effectively manage existing chronic diseases. And so employers are doubling down on prevention, primary care, reminding their workforce of the need to get annual screenings done, stay on top of vaccines where appropriate, and to live a healthy lifestyle.
You say employers are evaluating their partners. Have we seen them starting to make changes, or is this something that's just now emerging?
We have actually in our survey that we field every summer, we have seen a growing movement and interest in alternative models. They're still not mainstream, but we are seeing them slowly gaining a little bit by little bit every year growth in their market share. And so that's both on the health plan and on the PBM side.
Are you seeing an increased role for pharmacy?
We do. We one of the forums that we host here at the business group is our pharmacy benefit committee. It's one of the fastest growing committee with a lot of interest from all different stakeholders in the pharmacy landscape who want to have a seat at that table, who are innovating in this space and are really keen to speak and engage with employers about their capabilities.
And you say employers are reluctant, understandably reluctant, to shift costs to the beneficiaries. What other steps can they take besides the one you've outlined already of looking for new providers to try and rein costs in?
They are a number of different things that they're doing. They're looking at some of the things that they cover on the plans. I mentioned GLP-1s earlier. We do see a large number of employers who continue to cover GLP-1s for the treatment of obesity in particular in this context. And they are not necessarily stepping back from that, although they're putting some greater clinical oversight on those programs. They first and foremost want to make sure that when it comes to GLP-1 for obesity, that they are being appropriately dispensed and that not anybody and everybody is on them. It's not appropriate for everybody to be on them. So who is appropriate for that therapy? Are they under the right clinical supervision? Are they also engaging in the lifestyle modification that is required to be on those drugs? Are there other wraparound service providers that can also provide that oversight? And we've seen some employers, restrict dispensing of the GLP-1s to certain providers. We've also seen some employers put, different BMI or comorbid conditions on the appropriateness or the dispensing criteria for those. So that's one area that we've seen employers take a look. Other employers are looking at things like biosimilars and trying to promote adoption of biosimilars within their plan. So specific to prescription drugs, those are just a couple examples of things employers are doing.
And to what degree do you get involved in policy debates about pushing biosimilars, for example?
Yes, we have, as I mentioned earlier, we do have a very active policy and advocacy team. We're speaking to folks all the time about potential regulatory interventions, and certainly in the prescription drug space, we know that that's a very frothy area right now, whether it be PBM reform or transparency or drug pricing, most favored nation. Now we've got Trump RX and cash pay models. So we are, very actively engaged in those conversations and exploring both the opportunities, but then also some potential negative impacts to employer plan sponsors with some of those reforms. We also are very mindful of many of the policy developments in this area in particular have mostly been focused on the government-funded programs, not necessarily trickling over into the commercial market yet. And so we're very mindful and do bring this up in conversation quite frequently, is that sometimes the unintended consequences of that is that cost shift then occurs to the commercial market. So there might be savings on Medicare, Medicaid programs, but then some stakeholders might then look to recoup some of those profits by cost shifting to the commercial market, which of course is something we would not be hoping would be an outcome.
You call for employers to embrace change, to be open to new ideas. What sort of disruption is needed to make the health care system right? And can it be done? You say that government's doing this over here and it might have unintended consequences in the private insurance market. Does it need to be looked at holistically?
Disruption. I think, yes, we do need both market and policy-based reform. And when we talk about disruption, often, whether it be employers or just generally in society, people view disruption as a negative. There's a negative connotation. And we are trying to reframe that as the current state is highly disruptive. Changing from the current state does not have to be bad because the current state is negative. We have affordability challenges, we have population health that's declining, patient experience is subpar. And so we would posit that the current state is highly disruptive, and that in order to move away from the current state, there may be some near-term changes that might feel a little unsettling to people. It's maybe moving to a new health plan. It may be seeing that vendor in your employer's lineup become eliminated because they weren't delivering. It may be, reminding you that you need to live a healthier lifestyle or go get your annual cancer screenings done that most people would put off because it's inconvenient sometimes to do. So some of the things that we talk about might feel a little disruptive in the near term, but it's for hopefully the long-term betterment of the patient experience and outcomes and hopefully cost and affordability for everybody.
Ellen, let me ask you a final question. You talked about the fact that your group's been looking at healthcare for a long time. You talked about the acceleration in costs that we've seen in recent years. At what point does it become unsustainable? At what point do some employers say, we want to do this, but we can't?
We have been, the term unsustainable, I smile a little bit because we've been for decades saying it's not sustainable, but here we are decades later sustaining this. So one could argue that it is proven to be sustainable, sadly. We do, though, see many employers having to take a hard look at what they're offering, how they can continue to offer financial feasibility. Certainly when you're a smaller or even a mid-sized employer, if you have a patient on your plan who's requiring of a multi-million-dollar cell and gene therapy, that could bankrupt an entire health plan and perhaps even an entire company. So, some employers are having to do some, making some really hard decisions about what they're going to cover in terms of just financial viability of their overall organization, not just the health plan. We do see some employers at the smaller end of the market considering things like ICRAs or potentially, looking at ways to, cap their financial exposure. We've not seen that, more of the larger end of mid-market or certainly large employers aren't considering that yet. They might eventually. It's interesting, we talked just briefly about Trump RX earlier and some of these cash pay offerings that exist. And certainly we know that there are direct-to-consumer GLP-1 options out there. We may see some employers look at those options of not covering some of those things on their plan, but directing their employees to a cash pay model. I think that, again, has some unintended consequences. It leads to some inequities. So I think employers would need to take a hard look at that, not only financially, but from a, philosophical perspective to see if that, is cohesive with their strategy and their approach to, coverage for their workforce.
Ellen, thank you for your insights. I think our audience will be very interested in what you had to tell us.
Thank you so much for having me, Jeff.